Assalamu alaikum and good afternoon, all my colleagues watching out there. I am Dr. Habib Ahmed Khan. I'm a cardiologist at Maroof International Hospital. Uh, well, the subject for today's discussion is just incredible, and this is about statins. And as you all know, that statin is something which has brought a revolution in the field of cardiovascular medicine. The other day, I was going through an article about statins, and I came to know that there are more than 200 million people worldwide who are using statins daily. So, all my dears watching out there, we have in fact turned into a statin civilization. Today, we'll be touching two very important aspects about the statins. That is, who are the groups who benefit from the statin therapy, and what should be the intensity of statin therapy. And one very hotly debated question is about the pleiotropic effect of the statins. What are the other effects of the statins beyond lowering the cholesterol levels? And this is a very important part of the whole story. So the first slide is about the use of statins is to treat the risk, and it is not the cholesterol. What I've seen is in the modern practice and the modern perspective, statins are painted out as a cardiovascular risk reducing medication. So this is the basic concept of the today's discussion. It's a very basic slide which is showing that what are the benefits of lowering the cholesterol level. It has benefit in reducing the overall mortality in cardiovascular medicines. So what is the relationship between, is it okay? What is the relationship between LDL cholesterol, HDL cholesterol, and coronary heart disease risk? And it has been seen when we reduce LDL cholesterol by 1%, we reduce overall cardiovascular risks by 1%. And again, when we talk about the good cholesterol, this is HDL cholesterol, and when we increase HDL cholesterol by 1%, we reduce another 1% risk of the coronary heart disease. So this is a very basic slide which is showing, we know it from ages that there are modifiable risk factors for the cardiovascular diseases and there are non-modifiable risk factors. The risk factors which are smoking, dyslipidemia, high blood pressure, diabetes mellitus, obesity, your dietary factors, your lack of physical activity. And then there are certain non-modifiable risk factors like you have family history of coronary heart disease, your age and gender, which cannot be modified, but we can address these risk factors, and in future we can kind of risk stratify the patient and give them the guidelines accordingly. And if there are certain multiple risk factors in a single patient like smoking, hypertension, and hypercholesterolemia, this actually compounds your risk factors, risk of developing the coronary heart disease. So very unfortunate that still we have a huge burden of atherosclerotic cardiovascular disease worldwide, and it is seen that 16.6 million people worldwide they die of the cardiovascular disease each year, and 1/3 of the global deaths are contributed by cardiovascular deaths. Very important is to go through the guidelines which are being put forward by the American College of Cardiology and American Heart Association about cholesterol lowering. And in this, the cholesterol lowering guidelines were endorsed by National Cholesterol Education Program and Adult Treatment Panel 3, and now the upcoming Panel 4. A very important slide, looks very busy, but very important because we are addressing here the four groups who benefit from the statin therapy. Definitely one who has got a clinical atherosclerotic cardiovascular disease, like who has sustained an acute coronary syndrome, who has got a myocardial infarction, stable, unstable angina, or has undergone a any kind of coronary or any other kind of arterial revascularization. And it also includes the cardiovascular, also includes your strokes, TIAs, and peripheral arterial disease. Individuals who have got a primary elevation of the low density lipoproteins have an LDL cholesterol more than 190. If we go back into the risk stratification categories of different type of LDL cholesterol, the levels are between 100, 100 and 130, 130 to 160, then 160 to 190. And we have to risk stratify the patient, and accordingly we can address the kind of statins they require. Another group is the age group between 40 to 75, and they are the diabetic group, and their LDL cholesterol levels are mentioned. And this is another group who benefit from the statin therapy. Again, one who doesn't have a diabetes, but they have got such kind of cholesterol levels. And then we risk stratify according to different equations. And if the risk of developing atherosclerotic cardiovascular disease is more than 7.5% in the next 10 years, they also qualify, or they are eligible group for the statin therapy. Now, one very important thing is how intense should be the statin therapy. This you'll have to individualize according to the clinical scenario of the patient, but the general guidelines are that if you need to reduce LDL cholesterol by 30 to 50%, that's the patient requires a moderate intensity statin therapy. And the moderate intensity statin therapy is also recommended for the primary prevention of the patient, especially those who are having diabetes. And you all know that there are certain groups who are considered as coronary artery disease equivalent, and one of the group is the diabetes. The other are abdominal aortic aneurysm or symptomatic carotid artery disease or chronic kidney disease or symptomatic carotid artery disease. So these are the patients who are also candidate for the primary prevention statin therapy. So, high intensity statin therapy, I told you, is that required for the primary prevention in the patient who do not have an established atherosclerotic cardiovascular disease and diabetes, but their risk is more than 7.5%. I mean, the risk of developing atherosclerotic uh, cardiovascular disease in the next 10 years. If you require more than 50% of the LDL reduction, that means they require high intensity statin therapy. And the patients who have got clinical atherosclerotic cardiovascular disease, which you are usually encountering on the daily basis, patient with ACS or myocardial infarction, stroke, TIAs, and who have undergone revascularization. Recently it has been seen when you load the patient with statins who are undergoing PCIs or coronary intervention, there is tremendous benefit in terms of symptom control and in terms of recurrence of any kind of myocardial infarction. Different intensity statin therapy. This slide is showing that what should be the dose of the statins which is required in high intensity statin therapy and moderate intensity statin therapy. You can just go through these and you will come to know that how much dose of the atorvastatin or rosuvastatin or rest of the salts is required. So as I have already told you that high intensity statin therapy, that means when you are lowering the LDL cholesterol to more than 50% of the baseline, high intensity statin therapy is required. And very important concept is that is required for the primary prevention of the patient. That patient do not have established atherosclerotic cardiovascular disease, but they are not diabetic. Again, their risk of developing the disease is more than 7.5%. And one of the trial which was conducted in this context is the Jupiter trial. And this was basically targeted for the primary prevention of the patient. And in this, it has been seen that we can choose a statin for the primary prevention of such patients, and it has shown enormous results. This is the kind of patients who were screened out, and out of these 17,000 patients were randomized, and half of them were offered rosuvastatin in 20 milligram dose, and the other half was kept placebo. And these were the basic characteristic of all the patients who were endorsed in this study. The primary endpoint of this study was the occurrence to the first cardiovascular death, non-fatal strokes, non-fatal myocardial infarction, unstable angina, or arterial revascularization. And there was, as compared to the placebo, there was almost 44% reduction in the primary endpoint in these patients. And the secondary endpoint was a total mortality, and it was seen as compared to placebo, the group who was receiving rosuvastatin in the dose of 20 milligram, I think there was about 20% reduction in the total mortality. So it was a tremendous result. Again, this is a summary of the Jupiter trial, and the same I've already told you. So the results were very significant. So there is again a role of high intensity statin, specifically rosuvastatin, in slowing the progression of atherosclerosis. I'll skip these slides. This is about the Meteor trial, and this is basically for the carotid artery disease. Another very important trial was a statin study, and in these two very high efficacy statins were compared. And that was atorvastatin 80 milligram and 40 milligram of rosuvastatin. This was the flow of patients who were receiving either 40 milligram of rosuvastatin or 80 milligram of atorvastatin. And the results were compared based on the IVUS study. IVUS is intravascular ultrasound. This is just to know what was the atheroma burden on coronary angiography of these patients. And again, the result was very alarming in terms of control of atheroma volume, the percentage, and overall volume. And the results were again in favor of rosuvastatin. Rather than atorvastatin. Atorvastatin is helpful, but rosuvastatin in a lower dose and atorvastatin in 80 milligrams shown almost comparable results, but still the edge is in favor of rosuvastatins. And then there's another study which was Stellar Trial, and Stellar Trial was basically comparing the efficacy and safety of rosuvastatin in comparison to the other salts. And it was basically a 6 weeks trial. In 6 weeks, the patients were monitored for their blood cholesterol levels. They were offered different type of statins, and then they were followed after 6 weeks. And these were the different doses of various statins used. And amongst these, rosuvastatin was used in 10, 20, and 40 milligram, and atorvastatin, simvastatin up to 80 milligram, and pravastatin was 40 milligram. I was seen after 6 weeks. After 6 weeks, with rosuvastatin 20 milligram, the reduction in LDL cholesterol is by 52%. This was in comparison to the other salts which were though given in the very high dose, but the results were not as good as with the rosuvastatin. So basically, the take-home message today is that use of statins is to treat the risk, and it is not to target only the cholesterol. And in this case, you'll have to risk stratify the patient, individualize your cases, and then offer the treatment. And high-intensity statin therapy provides superior LDL reduction, provides superior primary prevention, provides superior atherosclerotic plaque regression, and is beneficial for the patient who are undergoing any kind of intervention. Thank you very much. Jikai. Do we have any local data for primary prevention of high statin? Well, we do not have any local data in terms of primary prevention. Well, for the primary prevention, I would say high intensity statin therapy is not recommended. You'll have to go for the moderate intensity statin therapy, and you'll have to risk stratify the patient. And according to the risk stratification, then you can offer which kind of statin therapy is required. Well, for this, if you go back to Framingham risk scoring, according to that, if the 10-year risk of developing atherosclerotic coronary artery disease is less than 10%, then you'll have to offer patient lifestyle modification, diet control, physical activity, and rest of the things. If it is between 10 to 20%, then probably you'll have to go towards the statin therapy, and you'll have to see the patient's cholesterol levels, whether it is falling under 100 or 130 to 160 range, or less than 130 or more than 190. And accordingly, you'll have to decide whether you have to offer high intensity therapy or moderate or low intensity therapy. And if the risk is more than 20%, definitely you'll have to offer them the high intensity statin therapy. Any experience for the user loading the statin?
Speak out करते ना ताकि लोगों को
Okay, so okay. The other question is any experience for use of loading dose of statin before PCI? Well, I think loading dose of PCI before statin, I do not have any experience, but a latest data is coming up in which it has been seen the patients who are undergoing coronary intervention, if they are loaded with the statin therapy, They have monitored the patient. I don't know how many months up later, and they found that the recurrence of myocardial infarction in these patients is much lower as compared to the patient who were not given the loading dose. Actually, the new data is coming up in this context. Okay. Do we have any local data for primary? I think this has been answered. Any other questions? Next, कहाँ पे आ रहा है?
देखो नेक्स्ट क्वेश्चन कैसे आता है क्वेश्चन करते हैं
Do you tailor your treatment to increase HDL, or you just follow LDL cholesterol levels only? Okay. For increasing the HDL cholesterol, you'll have to get back to the patient's physical activity, his diet control, and these are the basic things which increase the HDL cholesterol. And the medicines which were previously used for increasing HDL cholesterol, like niacin and rest of the things, they are laden with side effects. So that's, I think, is not a very good idea. And following the LDL cholesterol levels only, again, is not a very good idea, because first of all we'll have to target your LDL cholesterol levels, and then we'll have to go to the rest of the things like triglyceride levels. And again, you know, if the triglyceride levels are more than 500, then you'll have to target the triglycerides and then go back to the LDL cholesterol. Again, I would recommend you individualize the patient, you risk stratify the patient, and then offer treatment accordingly. Okay. Any experience? Again, that is the same question or the question. What? If there is any more questions, you are more than welcome to ask those questions. I think I'll go back to this question again. Experience of use of loading dose of statin before. I think this is a very pertinent and very valid question. And whosoever has asked it, I think there is the latest edition of Jack. Just go through that, and you will be knowing what there is a name of that study as well. I don't remember it. I've just gone through it a couple of days back, and that is, I think, very informative. I think no more questions.